Hello and welcome to the CTSNet Roundtable on Surgical Volunteerism. My name is Jay Powell from the University of Colorado. I've asked three of my colleagues to tell us about their experiences working overseas. We have Helen Marie Merritt from the University of Nebraska, Adel Hussein from the University of Utah Primary Children's, and Fred Grover from the University of Colorado. So Helen Marie, maybe we can start with you. Can you tell us what kind of work you've done overseas and how you got started?
Sure. My experience has been mostly in emergency response to medical disasters. The big one that comes to mind is following the Haitian earthquake. I had the opportunity to go over for about a week's time, actually immediately before the STS meeting that same year, and provide some emergency response to the victims of the earthquake over there. So we were at an orphanage that had been converted into a hospital, and we had a dentist office that we converted into an operating room and served about 800 people during that time.
How did you first get involved with that?
Well, my dad was the disaster response director for the Lutheran Church, and so he reached out to me during that time and asked if I would be able to go. Luckily, I had a lot of support from my faculty at San Antonio that let me go out on the mission with that, and it was an invaluable experience, both for myself personally and professionally.
And Adel, what type of work have you done?
Well, I've been really the benefactor of getting involved with an organization called the Palestinian Children's Relief Fund. It was started in 1991 by a journalist actually from Ohio. It's a non-for-profit, non-religious, non-political organization that focuses on trying to create less of a instability and lack of care challenge for kids in the Palestinian and Israeli region who don't get health care. So they organize different surgical subspecialty trips to go over every year. Their latest data shows about 13,000 kids getting some form of surgical care in that region every year. And so I got started with that organization in 2006 and almost on a yearly basis have gone to the region to help with creating congenital heart surgical programs. Since 2013, we've been going yearly to the Gaza Strip, which has been a whole new set of challenges and circumstances, but really rewarding.
That's wonderful. Dr. Grover, you've probably been going longer than the three of us combined. Can you tell us about that?
I guess that goes along with my age. I first got involved in 2000, 17, 18 years ago, with our Presbyterian church in Denver, and we had picked up half the cost of building a 80-bed pediatric ward in a hospital in Kathmandu, and basically went over. We had 45 of us that went over doing different things. I was with a medical group, and but part of it was to be sure that the money was being spent wisely and the construction was coming along, which it was. It was a beautiful project that came to completion shortly thereafter. But we did medical work. I worked with a cardiac surgeon at that time. There was one in Nepal, and they were doing less than 100 cases a year. This is a country with 28.5 million people and a lot of history of rheumatic heart disease and rheumatic valvular disease. So that was kind of my opening to cardiac surgery, and then I worked for a week out up close to Tibet and living in tents and working with the villagers there and our group doing some basic primary care work. And that followed that up after that by being interested in picking up on the cardiac surgery, and I've been back about 12 times now in that 18-year period for 2-week visits. And we work, I think what's a little unique about our group is that we've consistently, like you, consistently have gone back and built up a lot of tremendous relationships with the healthcare people there, the surgeons, and have watched it grow and have tried to promote their growth and tried to be sure that people that wanted to put money into programs there, put it into the programs that were taking care of people no matter what their ability was to pay, that type of thing. So it's been a very rewarding experience over the years. And the neat part of it is, and it hasn't got a lot to do with us, but except our encouragement and our taking, we lecture, we operate with them. We bring nurses that work in the critical care units with them, perfusionists, cardiologists, pediatric and adult. All of that, and do educational programs as well as in-hospital things. And now, thanks to the Thoracic Surgery Foundation and the Edwards Every Heartbeat Matters grant, we've been funded for that. This will be the 4th year, And that's allowed us to expand into remote clinics and where we try to identify people with rheumatic disease that may need an operation. If they don't right away, at least we have medical records set up now through iPads and with software for developing countries where we can track these people with contact information and that type of thing. We bought portable echoes so they continue that. We leave them with some of that money so they can carry it on the rest of the year. So it's a year-round program, but we're only there 2 weeks. So it's been very, very rewarding experience for us, and I hope for them too. So, but now they're doing 2,000 cases a year from what was 50 to 100 cases a year with pretty good results.
So very resource intensive, obviously. Helen Marie, when you go on a short-term acute need mission, what kind of resources do you have available? What do you take? What do you do with it when you're done?
Yeah, great questions. It really varies by what you might have at your disposal at the minute. So I'd say one thing is that on an emergency trip, they don't really need a thoracic surgeon. They need somebody who has some medical knowledge, who's willing to do whatever needs to be done. So probably 95 to 100% of what I did over there was not thoracic surgery. The only thing I can think of that I did that was even remotely thoracic was using a red rubber as a chest tube for someone who had a tension pneumo. So you sort of have to use what's at your disposal, and I think it does give you a little bit of insight into the fact that other people are making do with a lot less than us. You take some antibiotics, that's really important. You take pain medications, so basically non-opioid pain medications. And you have to be a little bit innovative when you're in that sort of situation. So we didn't have charts for people. We had a piece of paper that the Haitians knew they folded and kept at their bedside. And when a doctor or provider came by, they would unfold it and we would use that as their chart. So they were in charge of that. That would help us communicate with them. So a lot of innovative strategies to get by with what you have in the moment.
All right. And Adele, in Palestine, what was the state of congenital surgery in 2006 when you first went?
Well, there wasn't much congenital surgery, and a lot of those children, due to some supportive measures by the Israeli government, would go into Tel Aviv to get their operations, but it was a very challenging endeavor for those families to navigate that. We started operating in the West Bank at the time that I arrived in 2006, and seeing the program grow at a teaching hospital there was valuable because we wanted to impart the ability for them to start creating their own autonomous care delivery models. And so we, over the course of 2006, trained a thoracic surgical fellow to do congenital cases and created multiple teams coming in, primarily from Europe, on an almost monthly basis to really solidify the program at that hospital. We transitioned to the Gaza Strip in 2013 because we knew it was a portion of the country or the region that really just wasn't getting served. And so started from scratch again, built a bypass circuit, started to take our own instruments there, and started to build up their inventory. And I must say one of our challenges has been to create that educational platform there because of the lack of medical training and true training programs within the Gaza Strip. So the ability to create the platform for independent care delivery in the Gaza Strip's been a barrier that we faced, but we continue to plug away and hopefully we'll get there.
Dr. Grover, the first time I went to Nepal, I was struck that we helped a few patients, but in my mind I had trouble reconciling that we were actually changing the infrastructure, the overall ability to deliver care. But you've talked about Nepal going from 100 cases to several thousand in your time. What are the important aspects of what you've done over the last 17 years to make it so that the Nepal cardiac surgery system can sustain itself?
Well, that's a pretty complex question. I'd say the biggest factor was Dr. Bhagawan Karela, who spent a year and a half getting adult cardiac. They're all native Nepalis, the surgeons that I work with, and there are about 80, or there are probably about 10 or 14 of them now. He trained the vast majority of them, and perhaps all of them. He spent a year and a half here in the U.S. doing adult cardiac training, and then a year at the Hospital for Sick Children in Toronto, getting his congenital experience. And he's a superb surgeon and an excellent leader and organizer, administrator. And he, so we identified with him as a special person. And some of our local friends there that we developed acquaintance with on previous visits that had nothing to do with medicine by my son and daughter-in-law advised us to seek him out and work with him. And so working with him and his colleagues, he was originally at a heart hospital that the government built from an old shoe factory with 2 ORs, and that's up and got that going. And then they built another heart hospital over at the university, Tribhuvan University, for him to head up over there. So there are now 2, and he left a lot of these people there and brought some with him at the new one. And they, over the years, progressively built this up, and then we tried to work with them on the quality and that type of thing. One of the things that really impressed me, one of my first visits back after the first initial visit, was he had everybody in the room at this first hospital around a big table, and he said, what we want to do today is show you every death, every mortality we've had the last year, and have you analyze it and see what we could have done better. Well, I hardly wherever I visited in the U.S. does anybody pull out their worst results. And that degree of honesty and transparency really convinced me that this was the place I wanted to, center our attention on, are these places. So that's how we kind of got it going. But I would we add a little knowledge, update things when things are going on here, new technology, those kind of things. Particularly in the congenital area, we have, our congenital surgeons that go with us can offer a lot of help. And in the adult area, they're all pretty good in terms of the surgical things. I think you can always tighten up your critical care, your selection of patients, and that type of thing. And some need still in terms of more accurate diagnosis of the complex congenital defects. We had 2 pediatric cardiologists with us on this last trip. So that's how it really got going. But it was the leadership within. And then we had the opportunity over the years of meeting people involved with government and with health policy there, the non-physician types that steer the money and the resources too. And we could reinforce our opinions, to them on what to support. So that's how we got it going, and the results are quite good. And if you walked in their operating room now, 18 years after the first one, you wouldn't see a lot of difference from the U.S. Operating rooms in terms of the monitoring equipment, that type of thing, maybe in how they do things and the quickness with which they do them. But so it was just finding a great partner to work with over there and working with them and enhancing what they do. So we probably get more out of it than they do in a lot of ways. And, it's a very humbling experience to see people, as you well know, all of you that work in these international developing countries, what they can do with so much less than we have here. We get spoiled here in the United States.
The other thing that really struck me was my interactions with the people that we went with, the nurses, perfusionists, cardiologists, have changed significantly because you have a different appreciation for these people that are often younger than we are and spend their own money and take their own vacations to go do this type of work. And it changed how I interact with them back at home. Helen Marie, tell me some of the ways that your trips have impacted you personally.
I think I made a lot of great friends, people that I didn't know at all before the trip. We still keep in touch. We still contact each other. You go through something dramatic and share that similar experience, and it really bonds you as human beings for the rest of your life, it seems like. I guess the other big thing is just, like I said, learning to be flexible and to sort of see the forest for the trees. If you need to be a pharmacist for the night, be a pharmacist. If you need to hold a child's hand for the night, do that. If you need to be running patients back and forth from the clinic to the orphanage, then do that. Don't be set in your ways. Don't think that you're coming over there for one purpose. Really just see what the need is and don't be afraid to jump in there, even if it's a role you're not familiar with.
Yeah, go with the flow.
Exactly. Exactly.
Yeah, I would concur all those thoughts. I think you've shared some really insightful points in regards to the team you take over. We take about 8 to 10 people with us every year, and the sacrifices they make to come and really the dynamic that changes in terms of that team and those people then sharing those experiences with the remainder of our team when we return back to our home hospital is very profound. And I would echo Helen Marie's comments. I think you gain a different perspective about yourself. And a conversation I've had with several people that I've gone on these trips with is that you enjoy the purity of the care that you're delivering, because there's just not a lot of outside issues you're dealing with every day like you do just because of the nature of what we do here in the States. There's very little administrative work, there's very little political things that are going on. You're just focused on patient care, and it almost re-energizes you in terms of why you do what you do. And so those gifts that you get from the experiences in many ways outweigh, I think, what you're delivering there to those people.
Yeah, very true. And Dr. Grover, over 17 years, you must have some long-term friendships built up.
Oh boy, some of my best friends in the world. And as I've said before too, I think it's very easy when you're a cardiothoracic surgeon or a physician in the United States to have the entitlement mentality. And when you go do these things and you see what these people do for so little, with so little help, except themselves and their colleagues, it gives you an appreciation of how good we have it over here. And I've long advocated that all of our trainees should have an experience like this, just to put things in perspective, to let them know when we complain here, we have very little to complain about. And
So speaking of that, Helen Marie, if a student or a resident asks you, how do I get involved? What are the resources? What are the organizations that you point them to?
Yeah, I think it's a little different if you're looking to get involved in a one-time trip versus something more longitudinal when you're in your career or somewhere that you're going to be for a long time. The easiest place that I can say is if you're part of a church. It sounds like both you and I had that experience where it was a nice segue to connect with folks. Then you might reach out to other folks that you know that have been on similar trips and just let them know that you have interest in it. I think any of us are willing to be contacted about any available opportunities and put folks in the right way with that too.
What about for specialized cardiac care?
Well, you know, for me, historically, this all came about because I logged into the American College of Surgeons website, and back at that time, there was a ability for you to input all of your own personal information, and then they would link you with organizations that were good fits for you in terms of what you could provide. That being said, I continue to be impressed and amazed at the number of thoracic surgeons in our society that are doing these types of trips. And so I would encourage any student or resident to look around and ask questions, and you will easily find several people who have done this, who could be a mentor for you, who could get you involved, and really get you started on a process of having this humanitarian aspect of your career be very profoundly impactful on what you do.
Sure. And Dr. Grover, to finish, none of these trips are cheap. Can you talk about how these are supported and what resources have been important to you in doing this over the years?
yeah, I think largely we support ourselves, those of us that go, our travel expenses, and they're not insignificant when you go as far as Nepal or where you all are going. It's it could run $3,000 to $4,000 total. And the fact that our nurses who make less than we do by and large are willing to do that and take 2 weeks of vacation. I echo what you said about the sacrifice, the financial sacrifice and the time. We have the funding from the Thoracic Foundation Edwards grant, but we try to preserve almost all of that for the Nepalis by equipment with the echoes or leaving them with money to continue outreach clinics around the year when we aren't there, throughout the year. We have taken valves in the past. I've had a beautiful set of, 2 beautiful sets of pediatric cardiac instruments donated to us. In the past, it probably were worth $25,000 total on the American market. So we get help from industry on these trips as well in terms of equipment, that type of thing. We do try to save some money out of the grant to supplement the travel funds for some of our travel. We had 16 of us that went on this last trip, and not everybody can afford it, and this helps them be able to go. So it's been very, very positive from that standpoint. I echo what you say about the group. When they come back, they're excited, and they're talking it up in the ICU. I mean, the ICU head nurse came up to me the other day and said, our nurses really had a good time over there. It was a heck of an experience. And again, I think when you involve young people too, and I found that in our church, we would get scholarships for teenagers to go to these various mission areas. And once they've done it, they'll do it the rest of their life by and large.
We'll just finish. You mentioned the Edwards grant. This is the Every Heartbeat Matters grant.
Yeah.
And can you tell us a little bit about that?
So the Every Heartbeat Matters grant has been going on for 4 years now, as Dr. Grover mentioned. It is clearly focused more on valvular heart disease, but applications are accepted in regards to anybody doing this type of humanitarian thoracic surgical work. We really encourage people to get on the TCF website and apply for this grant on a yearly basis. And we've had great success in terms of providing several different teams and organizations with grant monies to promote this type of activity.
That's wonderful.
It's been very valuable.
That's great. Well, thank you, Helen Marie, Otto, Fred, for being here.
Yeah.
Appreciate it.
Enjoyed it.
Thank you.
Thank you.